Hello, I'm Hamimatul from Universiti Brunei Darussalam, and I am going to present on my research project with the title of Economic Evaluation of Patients' Own Medication, Unit Use and Ward Stock Utilization, Results of the First Pilot Study. Did you know WHO stated that 50% of medication supplied by the pharmacy usually goes to waste? Approximately 2.4 billion US dollars worth of medications were wasted per year in the United States. With these increasing issues of medication wastage, an economic-friendly intervention was worth to be evaluated, hence the reason for my presentation today. These will be the contents that I will be covering for today's presentation. Let's begin with an introduction to this research project. As mentioned just now, medication wastage has been causing a cost burden to the healthcare system that is worth millions of dollars. An economic and ecological friendly intervention such as using patients' own medications, POM, has proven to reduce wastage and save the cost spent by the hospital. From this part onwards, I will be using the term POM as a short form for patients' own medication. Due to that, the study aimed to pilot test the POM intervention in an adult ward settings and to perform the economic evaluation of using POM and ward stock during hospitalization. Now let me walk you through the method of the study. With that aim in mind, a prospective observational study was done among patients admitted to the medical and surgical wards of a public hospital located in Binti district, Brunei Darussalam. The study was carried out between February to April 2022. Moving on to the next slide, for this study, there were two aspects that were looked into, which are POM and ward stocks. Eligible patients include adults aged 18 years and above, patients that are on regular medications, patients admitted to the medical and surgical wards with a minimum of 48 hours and maximum 21 days. Regular medications here refer to medications that patients take on a daily basis, such as for chronic illness, which repeat prescription is usually given. So patients that were under the age of 18 and those with no regular medications were excluded, along with vulnerable patients, repetitive patients, and those patients hospitalized less than 48 hours and more than 21 days. Then the eligible patients were categorized into either two groups, the POM group and the non-POM group. The POM group was for the patients that brought their own medications during hospitalization, whereas the non-POM group was for the patients that left their own medications at home. In this study, the term POM is defined as the medications brought during hospitalization that patients acquired from the hospital's prescription or at the community settings. In the study, usually if patient brought their own medications, it will be checked and kept by the nurses in the trolley and administered to the patients accordingly. Since ward stock was also taken into account in this study, it refers to the use of the floor stocks kept in the wards. Usually in the inpatient settings, these ward stocks were managed by the nurses. And restocking the ward stock was done according to the approved list and supplied by the inpatient pharmacy on ad hoc basis. These are some of the pictures of how the wards kept their ward stocks, some on the trolley and some have their own shelves. These are some examples for the approved ward stock profile from one of the wards where they usually give the list of approved medications with the maximum quantity to be supplied. The reason for ward stocks being taken into account is because ward medication list for each patient was checked to determine which one was POM from inpatient pharmacy supply or from ward stock. To evaluate the cost analysis, several equations have been used and the cost price for each medication was based on the standardized medication price list by the Department of Pharmaceutical Services, Brunei, Darussalam. The price was also standardized to US dollar. So the first equation used was medication price per unit use over average length of stay multiplied by 100 days. This is to calculate the cost of medication use for both groups per adjusted patient days. This equation is derived from a previous study by Reiser and others 2017. This is the next equation used for calculating the real cost saved for using POM for the POM group. Then this is the third equation used in this study to calculate the expected cost saved if POM were used for the non-POM group. Since the study from Herpen, Mewison and others 2019 was used as a reference, the cost used was calculated using adjusted patient days for easy comparison. As for the statistical analysis part, all data collected were entered into Microsoft Excel and imported to RStudio for analysis. To compare between the non-POM and the POM group, independent t-test was applied, where p less than equals to 0.05 was considered as statistically significant. Next, moving on to the results section. After analysis, it was found that 205 patients were admitted to the 3 wards throughout the study period. However, only 112 patients were on regular medications, and in the end, only 104 patients were included in the study because 8 of the patients have length of stay greater than 21 days. Out of 104 patients included, 41 of them belongs to the POM group, while the other 63 were under the non-POM group. Now let me walk you through the summarized result. First, I will talk about the length of stay for both groups. If you can see, the length of stay for both groups was not significantly different, with 6.4 days for POM group and 7.3 days for the non-POM group. But for POM group, there has a slightly shorter length of stay compared to the non-POM group. Now let's look at the prevalence of regular medication used in the wards. From the study, it was found that more than half of the regular medications was used during the admission, although the result was not significantly different as well. Throughout the period of the study, $1,363 had been spent for the non-POM group and $531 for the POM group. This means the $531 spent was for the new medications prescribed for the POM group during their admission. It was calculated that $625 has been saved by using POM in the POM group, while for the non-POM group, it was estimated that around $759 can actually be saved if the use of POM is encouraged. During the period of the study, it can be perceived that the pattern of medications used for both groups were different, but ultimately, both groups have furosemide and different types of heart medications as the top medications used in the wards. It was also discovered that omeprazole had the highest number of medication used in both groups. Next, let's look at the aspect of ward stock used during the period of the study. Approximately $157 value of ward stock was used per month for the 3 included wards, and it was found that $18 was wasted from the ward stock alone due to expired medications. Moving on to discussion section. Comparing the results of the study with a previous study in Denmark, the pattern of result is almost similar, where the mean difference for both POM and non-POM group were insignificant, with the p-value more than 0.05. In this case, the mean difference was $2 for the previous study and $8 for the current study. There are few possible reasons for the insignificant difference of cost between POM and non-POM group. One of them is due to the addition of new medications and stopping of the regular medications during admission. Therefore, this increases the quantity of medications supplied by the inpatient pharmacy for the POM group. However, changing treatments during admission might increase the chance of abandonment of the previous medications, hence causing more wastage if not managed properly. Not only that, it may also increase the risk of drug-drug interaction and medication error, especially those with many medications. In the case of the expired medications found in the ward's trolley, one of the possible reasons is because of the habit of keeping the leftover medications supplied to the patients instead of returning the medications to the inpatient pharmacy, especially when the medications are not on their approved ward stock list. So one of the possible solutions is to use a unit dose system to supply the medications in the inpatient settings, although this might be labor intensive. Basically, unit dose system is where the inpatient pharmacy supplies the medications on a daily basis instead of supplying medications for a few days in advance. Traditionally, the inpatient pharmacy would supply patients' medications for 3 days in advance. So if there are any treatment changes, no medications will be wasted when using this system in the wards. This system has proven a net saving of €1,032 in a year by applying this system on oral antibiotics dispensing practices alone. So all in all, the use of POM helped to save 54.03% of the total cost spent by the hospital for the POM group. And it was estimated that the hospital can potentially save up to 55.7% in the non-POM group if POM is used. So, is it worth it to apply this intervention in the healthcare settings? Let's look through the promising benefits of POM. One of them is it can give better patient counseling by implementing continuity of care. Indirectly, this might also improve medication adherence during admissions, since patients are more familiar with the treatment regimen. Although the use of POM in the inpatient settings are time and labor intensive in adapting to the changes in the workflow system. This is because the quality of POM needs to be checked to ensure that they are safe to be used. Another challenge is that the use of POM may cause medication errors, as the quality of the POM cannot be assured. Therefore, implementation of the workflow system and standard operating procedures by involving a pharmacist in managing patients' medications in the wards and completing medication reconciliation might help in ensuring an effective patient care and reducing the prevalence of medication errors. In spite of that, there are both limitations and strengths for this study. The limitations include the fact that there were limited aspects covered where it only focuses on the cause impact of POM and ward stock, where the prevalence of post-discharge adverse events for both groups were not assessed. However, the data was reliable throughout the study as the researcher was able to utilize the BRUHIMS to screen medication utilization and closely monitor the patient's medications administration chart. In conclusion, the utilization of POM during admission is capable in reducing the cost spent by the hospital by at least 50% if patients brought their own medications. With the use of POM, total time spent for medication process can be reduced significantly for each patient. And if the total time is translated to cost, it will save a significant value. So this brings me to the end of my presentation. Thank you for your kind attention.